So our mission here at NCW Libraries is to connect people of North Central Washington to vital resources and opportunities that foster individual growth and strengthen communities. And just by you showing up here tonight, it really helps us continue to fulfill our mission. So thank you so much to our presenters and attendees for being here. And as you know, tonight's presentation is all about the prevention and the treatment of breast cancer. We have Dr. Smith and Dr. Straub from Confluence Health. Dr. Smith is the medical oncologist who has practiced in Wenatchee at Confluence Health for 23 years. That is a very honorable career, including a long-term outreach clinics in Omak and Moses Lake. So that's a lot of regional knowledge that she possesses. And Dr. Straub trained at the University of Utah and has been practicing in Wenatchee at Confluence Health for almost 11 years. So almost 35 years amongst these two. So we are very lucky to have their expertise with us this evening. So welcome, ladies. I will hand it off to you two. Thank you so much.
Great. Well, this is Dr. Smith here. Apparently my video isn't working, so you can't see me, but you can hear me. And I'm hoping you can see the slide. So what Dr. Straub and I are going to be talking about this evening is a higher level view update of what is breast cancer risk, screening recommendations, treatment that we use for breast cancer, what is breast density all about, and 3D mammography and some of the newer technologies, both from a medical oncology side and from a surgical side. So I like to say, let's put our best breast forward. Dr. Straub's going to tell us how to save the rats. When I think about breast cancer risk factors and the things that we talk to women and families about is, well, what are the basic risk factors for breast cancer? Women have a higher risk for breast cancer than men. And yes, men can still get breast cancer. It's not as common. It's more common in women because women throughout our lifetime have exposure to estrogen in our own bodies, that our adrenal glands are making hormones and pre-sex hormones, and our fatty tissue is also converting some of those pre-sex hormones into hormones throughout our entire life. And then when our period starts, so when menarche starts, that's the word we use, every month, as long as there's menstruation going on in a woman or having menstrual cycles, that's additional exposure to hormones. So sex is a risk factor, meaning female gender greater than male gender. Age is a risk factor. The incidence of breast cancer increases as we age. With each decade of life, there's an increased risk of breast cancer. And that just has to do with more years and more decades of exposure of our breast tissue to estrogen. I talked about starting, what age we start menstruation is important. So starting menstrual cycles earlier in life can be a risk factor, or going through menopause later in life than expected. Having what is the personal pregnancy history? Meaning having your first full-term pregnancy before the age of 30 is felt to be somewhat protective. So women who have never had a pregnancy and never had a full-term pregnancy are at slightly increased risk. That's felt to be a potential risk factor. Family history is important. And when we say family history, the things that we really are interested in and we'll ask women about when we meet them is, well, what are your first degree relatives? And have they had breast cancer? Have they had ovarian cancer? Did they have bilateral breast cancer? Any men in the family with breast cancer? And more importantly, or as important, if not more important, what age were those individuals? Breast cancer that occurs in a family in premenopausal women is a red flag to us that there's a risk within that family. Women who have had previous abnormal mammograms and undergone biopsies, if those biopsies show what's called atypical findings or atypical hyperplasia, for example, that has a slightly increased risk, and we talk to women about that. It turns out that the majority of breast cancers are actually benign, but that benign finding is a continuum. So on the right-hand side, or the more aggressive side of that continuum, would be atypical findings under the microscope. We now know that women who have increased breast density can be at an increased risk for breast cancer. hormone history means hormones taken by a woman, and hormones after menopause. We know that a combination exposure of estrogen and progesterone is a little higher risk than estrogen alone. We and other primary care providers and OBGYN and family medicine providers, you caution women now or talk with them that if there's a reason and a true indication to take hormone replacement therapy after menopause, that should be continually discussed over time. And as soon as that can be weaned off, to do that. Women who have had, or individuals who have had breast radiation or chest wall radiation in their past could be at increased risk of breast cancer. For example, young adults who have a diagnosis of Hodgkin's disease oftentimes have radiation to the center part of their chest where the lymph nodes live. Well, we know that within 10, 20 years down the road, we need to start screening for breast cancer in those individuals. In some families, we know already that there's a gene that's inherited and has been identified in those families. Some of you may have heard of the BRCA1 and 2 genes, for example. Some of those genes that are inherited and passed on through generations can put those carriers at increased risk, up to 85% lifetime risk of breast cancer developing. Knowledge is a pretty powerful and important tool. So knowing your personal history, knowing your family history, knowing your personal risk, knowing your medical conditions, and knowing what you can modify, I think are important prevention things to consider. So lifestyle modification is a form of a treatment. It's a preventive treatment. So lifestyle modification means healthy diet, a diet heavy and high in fruits and vegetables. We generally tell or advise women and cancer survivors to eat a diet that has 5 to 9 servings a day of vegetables. What exercise means is intentional movement of your body on most days, ideally aiming for minimum 150 minutes a week of moderate activity or higher. We do know that many cancers are associated and can be increased risk by tobacco and alcohol use, and breast cancer also has a slightly increased risk in women who use tobacco and alcohol products. We do know that there are some, and we prescribe some preventive medications. If a woman has a relative 5-year risk of 1.6 to 2 or greater compared to the average risk, we'll talk with them. What are the pros and cons of taking an anti-estrogen or an estrogen modifying medication to decrease their risk of breast cancer? Another preventive tool and knowledge is genetic counseling and testing, finding out when appropriate, is there a gene that this individual has inherited, and do we have any specific recommendations based on that piece of DNA? Women who are at increased risk and choose to undergo screening, we may recommend intensified screening. And what that may mean, for example, is a mammogram alternating 6 months with a breast MRI, then 6 months later a mammogram, alternating 6 months later with a breast MRI. And in some cases, for example, in BRCA1 and 2 gene carriers, those women may even opt for preventive mastectomy long before a cancer has a chance to develop. So what's the most common screening tool for breast cancer? I'm sure everyone has heard the word mammogram or mammography. So this is a picture of a standard mammogram machine. A mammogram is a low-dose X-ray to examine the breast tissue to see if there's any abnormal calcifications or masses or densities. It's important that breast compression occurs so that a good image can occur. Sometimes motion can cause blurring on a mammogram. And so when a woman comes for their mammogram and the technician puts them into the position standing up against or into the machine, oftentimes women are told, hold your breath, and then they'll release it after the pictures are taken. Some limitations of mammogram would be implants can sometimes obscure the pictures that can be taken. And women who have very dense breast tissue, that can be difficult to read the mammogram. And there's an occasional or rare cancer that is unable to be detected on a mammogram. For example, lobular breast cancer is one that we think of commonly that may have a mass that is palpable, meaning felt by the patient or the physician, but it not showing up on mammograms. And when we have a mass that's palpable and unexplained, we need to take that workup a step further with ultrasound and biopsy when indicated. There's different types of mammogram, and it used to be in this country and most of the world that only two-dimensional mammograms could be performed. What that means is a two-view X-ray of the breast from top to bottom and from side to side. There has been developed better technology called three-dimensional or digital breast homosynthesis, where multiple images are taken of the breast. And this is a picture on the right-hand corner of what the mammogram machine looks like. And you can see at the top part, the part of the machine that actually takes the images rotates in an arc. So the breast is reconfigured three-dimensionally for the radiologist and can help decrease false positives and lead to improved unnecessary biopsies, for example. Here at Confluence Health, we use three-dimensional mammography. Here's an example on the left-hand side. This is the same breast, the same woman on each image here. On the left-hand side is a standard two-dimensional mammogram. And you can see somewhat the outline of the skin, and you can see the blood vessels and some of the ducts coursing through the breast and a little bit of breast density. And you might say to yourself, well, I somewhat see a density or an area that looks a little bit different than the rest in the lower mid portion. Well, here's the three-dimensional view of that same breast to give you an idea of how much more powerful of a screening tool three-dimensional mammogram is. And this mass just pops right out and is easy to detect on three-dimensional mammography. So breast density, I discussed earlier that breast density can be an increased risk of breast cancer in some studies. It is now required in many states, including Washington state. There is a requirement by law that breast radiologists, breast imaging doctors are required to report on the mammogram if there's increased breast density. So those of you, and if you look at your mammogram report over recent years, you will see that called out. Here's an example of breast density and how that changes what a mammogram looks like. So on the left-hand side is a breast that is mostly fat. And here's the wonderful thing about menopause. As we go through menopause and later in life, the normal density of the breast turns more fatty, so it becomes much easier to read mammography. But here's an example on the left of a breast that's mostly fatty tissue, so you can see right through that mammogram. And then next on the right is a medium amount of density or a moderate amount of density next over. And then on the far right, this breast mammogram or mammogram of a breast that has substantial or extreme density, it's very difficult for the radiologist to find very small findings or new or abnormal changes. So this is why breast density is important, that if the breast density does not show something that we're concerned about, we're going to take that prevention and that screening and that imaging to the next level. So some women are worried about, well, I can't afford a mammogram. And that really is no longer the case for a number of years. In Washington state, all insurance plans are required by law to cover three-dimensional mammograms without a copay. This is for screening mammography. Medicare is also required to pay for screening mammography. There are also state programs for women who don't have medical coverage or medical insurance that they may qualify, that not only helps cover any findings after a screening mammogram that may lead to a diagnosis or other interventions or biopsies or treatment. And that's called the Breast and Cervical Healthcare Program. Some women are concerned, or they'll say, I'm nervous to get a mammogram because I've heard that it's radiation exposure. And won't, over the years I have a mammogram, I be at risk of radiation just from having mammograms? So they've actually measured and they know what is the radiation exposure from a mammogram. From a 3D mammogram, that equals 1/6 or less of the radiation that we receive each year from natural sources all around us in the environment. So felt to be very safe. And again, at Confluence Health and our outlying clinics and outreach centers, we use 3-dimensional mammography. It is important, and they have signs up in all radiology departments in the country, that if you feel you have the possibility that you may be currently pregnant or are pregnant, you need to let the technologist know that, so the appropriate precautions and safety measures can be taken for the unborn child. So breast cancer screening. Well, some of the big questions: when should you start mammography? How frequently should you undergo mammography screening once you've started your screening? And then when to stop mammography as you age, depending on your comorbidities in life. There's lots of different professional societies in medicine. And the confusing part, and in a bit, I'll have a slide that shows you why this might be confusing to some, but the confusing part is some societies have a little bit different recommendations. And we'll talk through, well, how do you sort through that with your primary care provider to know what is best for you personally? And just like any screening test or treatment, there may be potential benefit versus harm. And so the benefit is higher when the risk is higher, or when the incidence is higher of the condition that you're screening for. So personal preference. How worried are you about developing breast cancer? Do you come from a family that has many generations of multiple people who've had breast cancer? Do you have a family member who was premenopausal with their diagnosis? How reassuring would it be for you to know that your mammogram was normal or not? Now, that may change throughout your lifetime, the answers to those questions. How important are the false positives or overdiagnosis or overtreatment? So what those words mean are, given the majority of abnormal mammograms that turn out to be benign, to prove they're benign means other treatment or other imaging modalities may be necessary, like a diagnostic mammography or an ultrasound or a biopsy or a breast MRI. So sometimes these false positives, we refer to them as a scare. Some patients will come in and they'll say, I had a scare with my mammogram, or I was really concerned they had breast cancer, went through a bunch of testing, it turned out was negative. So starting screening mammograms at age 40 instead of age 50 does slightly decrease the risk of dying from breast cancer. How important is that gain to you if you are in that age group? And that overall gain of life saved in that age group is around 1 in 1,000 women. How would you feel if you chose not to get mammograms and then later on were diagnosed with a breast cancer? So those are all things that maybe those answers or those self-values or goals of medical treatment may evolve and change over time and over years, depending on your underlying health and comorbidities and what's happening within your family. It's also important to know that family histories can change over time. So if we look at it, I'm going to break it up into 3 age groups: ages 40 to 50, age 50 to 74, then age 75 and older. So the big questions for age 40 to 50 is, when should I start mammography? And then how often? So to answer that question, it's important to understand your personal cancer risk. Then weigh the benefits of harms versus benefits of screening, and then discuss, personalize that decision to yourself. Here at Confluence Health, we did a lot of work for a number of years as a multidisciplinary group and came up with patient decision aid information handouts and tools to work through a lot of the nuances of these kind of questions. Personal risk, we talked about some of the risk factors for breast cancer before. So knowing if you have those, making sure that your doctor or your provider knows that you have those risks are important. At Confluence Health, we do recommend that women have their first baseline mammography, if not by age 40, then by age 45 as the latest, to get a good baseline. And then based on those findings, personal cancer risk, etc., determine between that age and age 50 how frequently to continue. So some of the benefits of screening mammography between age 40 and 50: early detection, picking up a cancer, for example, prior to any symptoms. So the earlier a stage of cancer is found, the more likely we are going to be to cure that. It may be much easier to treat at lower stages. Around 1 in 1,000 women are less likely to die from breast cancer in that age group when screening mammography is performed. And these are from multiple international studies that give us that number. We talked about the minimal radiation exposure that is felt to be a very low risk screening, knowing that there may be some false positives or some scares, and that may lead to some over treatment to figure out who's a false positive or not. So then if we go to ages 50 to 74, it's not a question of should women in that age group have mammography screening. Yes, they should. The question is how frequently. Should that occur every 2 years as a minimum or every 1 year as a minimum? So again, understanding your personal risk, personalizing that decision to what's going on in your body, in your family, in your past medical history, and discussing that decision with your provider. Some of the benefits: again, early detection and treatment may decrease the chances of dying from breast cancer. The benefits of screening, I mentioned this earlier, increase when the group or the population of people you're screening has an increased incidence. So as a woman ages through the years in this age category, that risk of breast cancer may also increase. Again, some of the harms may be false positives, overdiagnosis, overtreatment, ongoing minimal radiation exposure, so a low risk procedure even in this age group. Here's a table, an example of some of the national medical societies in this country and what recommendations they have. So you'll see at the top, the American College of Radiology recommends every year mammogram between the ages of 50 and 74. The American Cancer Society actually changed their recommendations a few years back. And they're now recommending that ages 50 to 54 every year. And then age 55 and older, consider going between 1 and 2 years, depending on all of these factors. The U.S. Preventive Task Force, every 2 years as a minimum, if justification to go every year, depending on risk factors. The American OBGYN Society, every 1 to 2 years per informed personal choice. So that's a shared decision-making going through all of these things. And then you'll see the family physicians and the American College of Physicians there. So what about women who are over the age of 75 or older as we enter those later chapters in life? The biggest question is how long to continue screening mammography? How long do I or you want to continue having those screening mammograms? And I always ask women when they ask me, well, what would you do, Dr. Smith? I say, would we act upon the result? Are you in good enough health, and is your life expectancy and prognosis from your other medical conditions such that we would act upon an abnormal finding? And that sometimes helps clarify those decisions and those discussions for women. If you look at this graph here, younger women are in good health. A mammogram is more likely to extend how many years additionally they may live. If you take a woman, for example, who's 93 years old, having a screening mammogram is not likely to allow a woman in that situation to live longer than her life expectancy already is. And you'll see this is from an actuarial life expectancy table. If somebody is currently, as of this past year, age 75, current life expectancy is another 13 years versus age 80, 85 is another 7 years. Current life expectancy age 90 is up to 5 years. So again, personal preference. And we talked about all of these same concepts for every age group. And then again, in this age group, one of the most important, are you in good health? Are you in good performance status? Do you have a lot of underlying health conditions that limit how you do your activities of daily living every day, for example? Activities of daily living include the activities of being a human being on a daily basis. People who are pretty impacted by their medical conditions that they no longer can perform their activities of daily living, they may opt out of these kind of screening tests earlier in life. So another table for the different society groups for age 75 and older. So both the American College of Radiology and the American Cancer Society say the age to stop depends on the health status and life expectancy. A couple societies say, you know what, there's just not enough data to recommend either way. The OBGYNs say personal informed choice. So moving quickly on to treatment. One of the big take-home messages is care should be personalized. This is not a gunshot approach and treat all breast cancer patients the same way. When I say personalized care for each patient, that means the best care, the standard of care, and no less based on what is the size and stage of the cancer. That means how big is the actual cancer in the breast? Has it gone to any lymph nodes? Has it spread to other areas in the body? Has it involved the muscles of the chest wall or the skin? Those are all situations that can change and will change the stage of that cancer that's assigned. And that changes our goals of care and our treatments that we recommend based on stage. Is a breast cancer invasive, meaning growing through the lining around the ducts and the lobes and the lobules, or is it non-invasive? So there's a form of non-invasive breast cancer called ductal carcinoma in situ, or DCIS. That's stage 0 breast cancer, the most curable form of breast cancer. And in some circles, it's a debate, should we treat that or not? Well, that depends on age and years left to live and underlying health status. But these are things we consider. For example, non-invasive breast cancer, we never recommend chemotherapy. But some invasive, higher risk or higher stage breast cancers, we will recommend chemotherapy, for example, as part of the treatment if that helps decrease the risk of return. Another really important determining factor of part of the treatment we recommend, is this breast cancer hormone receptor positive? That means estrogen driven or progesterone driven. So most breast cancers are estrogen driven. Two-thirds to 3/4 or more of breast cancers are driven and estrogen receptor positive. So as part of the workhorse treatment modalities that we recommend and prescribe are oftentimes pill form of treatment to decrease the estrogen that's available in the body or prevent estrogen from binding to those breast cells. Every invasive breast cancer is tested for additional DNA mutations. And there's a specific DNA test or gene test called HER2/neu. Those breast cancers, if that gene is turned on or overexpressed, they can be more aggressive and we treat them more aggressively. Well, we have specific targeted treatment just for HER2/neu breast cancer. That's a form of monoclonal antibody combinations, for example. There's a unique type of breast cancer called triple negative. That means estrogen and progesterone negative, HER2/neu negative. We now know, as of this past year and a half of international clinical trials, that immunotherapy in combination with chemotherapy is very important and improves the overall survival and response in those cancers. Metastatic breast cancer in a woman who has an underlying BRCA gene mutation, and those can run in occasional or rare families, we have targeted oral medications that specifically block that gene and really get down to the root cause. There's also a rare form of breast cancer, inflammatory breast cancer. Those are the breast cancers that involve the skin when they're found. The skin of the breast may be red or warm or feel like a rash or swelling of the skin. The swelling of the skin may look like an orange peel. Inflammatory breast cancer we treat very specifically. Upfront chemotherapy, then radiation, or then surgery, excuse me, then radiation, then anti-estrogens if estrogen positive. And most importantly, can this patient tolerate this treatment we're recommending? Is there any contraindications? For example, a really important thing that we will ask women in medical oncology when we're talking about anti-estrogen pills includes, have you ever had a blood clot? Have you had a DVT? Have you ever had a pulmonary embolism? Are there any blood clotting problems in your family? And I'll be honest and say some women have a strong preference against and or for certain treatments if we recommend them. There are some women who may choose a specific surgical path because they don't want to undergo radiation or they live many hours away. So some women have underlying preferences that they come into this diagnosis with that they may have about treatments that they would accept or not. So I always divide breast cancer treatment up into two categories. The first is local regional treatment. That means what happens to the breast, the chest wall, and the armpit area. The armpit area is called the axilla. That's where the lymph nodes live. So typically surgery occurs first, unless there are certain circumstances that we need to give treatment before surgery. So surgery, Dr. Straub will go into that in greater detail. There's a couple options there. Remove the lump or remove a bigger breast. At the time of surgery, the lymph nodes are typically sampled. Not everyone needs removal of all of their lymph nodes. And in fact, I'm happy to say that it's a thing of the past to hear women who have 20 to 30 lymph nodes removed. Now it's much more common to have sentinel lymph node or lymph nodes removed and not have to go on to a full lymph node dissection. Radiation is also a form of local breast treatment. When a woman chooses lumpectomy, that means leave the breast intact, and treatment we call breast conservation, to conserve the breast. That involves lumpectomy followed by radiation. When we look at the local cure possibility of lumpectomy with radiation versus mastectomy, the local cure of those two comparative treatment pathways are felt to be equal. Now, the radiation doctors, that's an entire other detailed and very specific specialty. They talk with each patient about what is their field of radiation, how many treatments will radiation be. It used to be, even 15 years ago, that breast radiation was typically between 35 and 42 or 43 treatment days. Now, after lumpectomy, radiation can be given in as few as 5 treatment days or 16, depending on the dose per day. And there's different forms of radiation. We have some of these options here in North Central Washington. For some of these options would be more in bigger academic centers, such as the seeds and pellets and intraoperative radiation. That means radiation machine is brought into the operating room at the time of surgery. Here's a picture of what a typical radiation machine looks like. So this is called a true beam or external beam radiation. The patient lies down on the table. There's a treatment planning process that occurs as the radiation physician and team is gearing up and designing the fields with conformal, like GPS, three-dimensional fields. A couple small tattoos are put on the skin about the size of a freckle, and this arm of the radiation machine will move. So the act of having radiation treatment on a given day is like having a chest X-ray. That radiation treatment that day has minimal side effects. So how about systemic treatment of breast cancer? And then we'll move on to Dr. Straub's portion of the talk this evening. So the word systemic means the body-wide. In the cases where this is curative intent treatment, that means stage 0, stage 1, stage 2, stage 3 breast cancer, we're trying to prevent any recurrence or prevent metastases of breast cancer. So that's body-wide. Then there's women who have stage 4 breast cancer. That's metastatic. And those women or those cancer patients may not felt to be curable for the most part, but they're still treatable. And the majority of metastatic breast cancer patients that are estrogen driven, we think of metastatic breast cancer as a chronic illness, just as we would think as heart disease or diabetes or congestive heart failure. Some of those women may live multiple years. I've had women in my practice with metastatic breast cancer living 17 to 20 years on anti-estrogen forms of treatment alone. So it's a very variable and personally unique condition in those settings. I will say that one of the standard treatments for any woman with estrogen receptor positive breast cancer is hormonal therapy. And that typically is 5 years as a minimum of an anti-estrogen pill. So hormone therapy is not chemotherapy. Before menopause, we use tamoxifen. After menopause, we typically use a different type of anti-estrogen pill called aromatase inhibitors. We have injection forms of anti-hormone or hormonal therapy. We will sometimes purposely put a premenopausal woman into menopause, that's called ovarian suppression, to further decrease estrogen load depending on what type and stage of breast cancer they have. So there are some instances where we also may recommend chemotherapy, and I'm going to say that's very personalized to the risk of that cancer. The stage, the DNA profile, we will send very frequently now on the early stage breast cancers where there may potentially be a small risk, but we want to know, is that higher than is the risk of chemotherapy of greatest benefit, then it's higher than the side effects. We will send a DNA test on the sample called Oncotype DX that looks at 21 different genes. I call it the rap sheet of the cancer. So it tells us, is that a bad actor cancer based on those 21 different DNA and gene mutations, or is it a low risk breast cancer that's not going to benefit? Systemic treatment may also include targeted therapy. We have monoclonal antibodies against some gene products. We have some monoclonal antibodies that are conjugated, meaning hooked on to chemotherapy. So they act as a smart bomb, if you will, targeting just those cancer cells in the body. And we have oral targeted treatments. Many of these are directed towards specific genes and proteins. Immunotherapy is a newer kid on the block in cancer treatment, I'll say, over recent years. And there are many cancers that we now prescribe immunotherapy as a standard. Well, a newer approval and international published phase 3 trial is in triple negative breast cancer, showing additional benefit of using immunotherapy in combination with chemotherapy, both before surgery and after surgery. So that has changed the treatment recommendations for that type of breast cancer during 2022. None of these treatments where we are currently, but more importantly, where we will be in the future, would be possible without ongoing clinical trials. So this is why, for example, childhood leukemia that used to take the lives of the majority of children who had ALL or acute lymphoblastic leukemia, the majority of those children are now cured because of clinical trials and research going on in many institutions across not only this country, but the world. And there is ongoing clinical trials for breast cancer. And some of those clinical trials are early stage breast cancer, and many are in metastatic breast cancer. And here at Confluence Health in North Central Washington, I'm happy to say that we have had an active oncology clinical trial department for 20 to 30 years. And in fact, one of the landmark HER2/neu treatments for upfront breast cancer, we enrolled the first patient in the international clinical trial for an oral HER2 drug. So I'm very strong advocate for clinical trials, and if that has the potential of benefiting a patient, it should be considered. We discussed that in metastatic breast cancer, the treatment goals may be different. The treatment goals may be improving quality of life, improving cancer-related symptoms, improving cancer-related quantity of life, and not hurting somebody in the meantime while we're treating their cancer. I'm also going to say that in some cases, we recommend genetic counseling and testing because that could offer different treatment options. Survivorship is a concept that begins on day one. Some people think survivorship is only if your cancer is cured, and I'm going to argue strongly against that. And survivorship is for any patient, not only that has a cancer diagnosis, but not only breast cancer, but any cancer or any other chronic medical condition. So survivorship includes not only what stage was my cancer, what treatment did I have, what were the medicines used, what are the long-term side effects me and my primary care provider need to be on the watch out for the next 5, 10, 20, 30 years. How do I prevent future cancers? What screening program is recommended for me? What about diet? What about oncology nutrition counseling? What kind of exercise do I need? Spiritual goals of care. That's all part of survivorship, is living better during and after a cancer diagnosis. So we recommend that anyone who has been through cancer treatment or ongoing cancer treatment consider to be seen in our survivorship clinic. We also have a survivorship rehab program. We partner with Central Washington University Exercise Physiology Program and the YMCA and offer a 12-week cancer survivorship rehab program every year. And that's open to all cancer patients, not just breast cancer patients.
All right. Hi, everybody. As Julie just said, I'm Dr. Kate Straub. I'm one of 6 general surgeons here. We all do breast cancer surgery, and I am here specifically to present how I talk about breast cancer surgery and my evaluation of breast cancer with patients. So we're going to talk about surgical options for the management of breast cancer. So what we're going to talk about during this lecture is what to expect during your visit. Very importantly, the surgical management of breast cancer in this day and age. But we're also going to touch on breast reconstruction, even though we don't do it here in Wenatchee. I find a lot of women don't really want to make the leap towards mastectomy without knowing what reconstructive options are available to them. And then a little bit about how to prepare for your surgery and what to expect afterwards. As Dr. Smith alluded to, we have a very team-based approach here with medical oncology, with people like Dr. Smith, surgical oncology with people like myself. That's Dr. Coomer in the lower left with radiation oncology, and Kim Hinson, our nurse navigator, who's our go-to person, the person for most patients to reach out to when they initially have questions. And we also have a cancer conference that allows us to discuss the more complex breast cases and come to a good consensus amongst all of us so that patients are getting the best team-based approach. So how do you prepare for a visit with your providers? You may actually see all 3 of your medical providers on the same day, which can be great and efficient and so informative, but it can also be very, very daunting. Or you may see us all separated, especially if you have a specific request for who you want to work with. Regardless, wear comfortable clothes. You are going to be examined by each and every one of us, which can seem a little annoying and daunting, but we each have our own specific goals of trying to figure out how to tailor your care. So clothes that are easy to come on and off, at least from the waist up. You should definitely bring somebody with you if at all possible, or take notes yourself. We only expect patients, especially those receiving news about a new cancer, to remember about 20% of what is presented to them. So having somebody else there to remember some of the rest can be very helpful. And also expect repetition. What Dr. Smith tells you, what Dr. Coomer tells you, you, what I tell you is catered to our specialties, but should sound very similar across those specialties. And part of that is we know you aren't going to remember everything from the first visit. And hopefully by the third, everything is just starting to make a lot more sense. All right, so whenever I meet a new cancer patient, I discuss it the exact same way, and I use a very specific template. So I figured I would just go through that with you all because I think it'd be very helpful. So the first thing I do is discuss the 5 aspects of every breast cancer that helps me decide as a surgeon how aggressive I need to be during surgery. The first thing, obviously, is the size, as Dr. Smith alluded to. The larger a breast cancer is, either the longer it's been there or the faster it's growing. And we divide up the size of breast cancers into 4 what we call T stages. So that is from smallest to largest, where T1 is less than 2 centimeters, which is about 3/4 of an inch. T2 is 2 to 5 centimeters or up to about 2 inches. T3 is anything greater than 5 centimeters. And T4 is actually any size where the mass itself comes into contact with or is stuck to either the chest wall or the skin. Then we talk about the grade, which Dr. Smith also alluded to. And this is when the pathologist does the biopsy and they're looking at the individual cells on the slide, how disorganized and aggressive do those cells look? Do they look like they're turning over to become new breast cancers quickly, or are they kind of bland and doing it more slowly? And you can kind of see the levels of grade 1, 2, and 3 here. Then Dr. Smith also talked about estrogen and progesterone receptors like docking stations on the edges of cells that allow different hormones to stick to and turn on and off part of those cells. And as you can see here, and certain breast cancers have estrogen and progesterone receptors, allowing your body's own natural estrogen and progesterone to turn on the breast cancer. Now, that sounds like a bad thing, but we also know that most cancers with these receptors tend to be a little earlier and easier to treat, as Dr. Smith talked about those hormone receptor blockers. Then there's HER2/neu, that gene Dr. Smith mentioned. This is an actual look at the gene, not something you pass down to your loved ones, something very unique to your cancer that can let us know how aggressive it is. And finally, the lymph nodes. We know that breast cancer spreads away from the breast. The first place it tends to go is the lymph nodes in the armpit. And at this stage in the game, we mostly just know that from direct palpation or feeling anything abnormal, or sometimes it can be picked up on an ultrasound done during your evaluation. So when I'm going through this with a patient, this sheet might look something like this. And you have somebody with a relatively small, but maybe biologically more aggressive looking tumor, but has estrogen, progesterone receptors, not that more aggressive gene, and hasn't spread to the lymph nodes yet. So next, in the lower part of my template, we talk about surgically, what do we do with that information? And I always talk about the lymph nodes first, because regardless of what you choose to do to your breast, we do essentially the same thing to the lymph nodes. And now I want you all to imagine all the lymph nodes in your armpit lined up as if they're in a pyramid. And in order for cancer to get to all the lymph nodes at the bottom of the pyramid, the first place they set up shop is those first few lymph nodes at the top. And then they have to move down to the rest of them. So if we can remove just those top lymph nodes, known as the sentinel lymph nodes, and there's no cancer in those lymph nodes, then we feel reasonably assured that there's no cancer in the rest of the lymph nodes in your armpit, and therefore your breast cancer most likely has stayed localized to your breast. So how do we find those lymph nodes? Well, it doesn't look at all like a pyramid in there. It's kind of like a crazy spider web, and those lymph nodes can be scattered anywhere within that spider web. So we have actually 2 ways of identifying the lymph nodes. They both involve injections done around the nipple. The first is a radioactive dye that is injected around the nipple on the morning of surgery. And then it gets pulled up into those lymphatics and gets clogged up in those first sentinel lymph nodes. And I have a wand like a Geiger counter that beeps loudly when I get near them. But because lymph nodes are small and roughly the color of the tissue that surrounds them, I also use a blue dye injected around the nipple. And it can kind of look like this when it's injected. So you can expect some blue discoloration to your breast at that time. It does the same thing, gets sucked up into those lymphatics. And I use that Geiger counter to point me in the right direction. And as I get closer, the lymph nodes look bright blue like this. And you can even see the lymphatic channel coming right in. One thing I always like to remind patients is that if you have that blue dye injection, you'll pee blue for a few days. That's totally expected. Now let's talk about the breast itself. With the breast, we have two options. It's much more complicated than that, but 2 main options of mastectomy, which is a simple mastectomy requiring the removal of the breast nipple and the sentinel lymph nodes, or breast conservation, which almost always includes both lumpectomy and radiation therapy. And you can see here just removal of the lump itself through a much smaller incision. So, how do we decide between these two? Well, patients are always concerned about, is their breast cancer going to come back? And they want to be as aggressive as possible to avoid that most of the time. And what I tell them is that even with mastectomy, your risk of having your breast cancer recur is not zero. It's impossible to remove every last breast cell and separate it from the skin cells. And therefore, I quote them a risk of about 1% that your breast cancer could recur with mastectomy. Now, with breast conservation, initially just with lumpectomy, the risk of recurrence was much too high. But with modern lumpectomy techniques matched with modern radiation techniques, the risk of having your breast cancer come back is 4%. Now, that's not bad, but it is 4 times higher than mastectomy. So, why do we feel comfortable offering breast conservation to patients? Well, most of my thoughts on this come from a paper that's actually almost 20 years old at this point, but it was a very well respected, very large trial that compared women who did mastectomy and women that did breast conservation therapy, and followed thousands of these women out for the rest of their lives, and found that regardless of what breast surgery you chose, your risk of dying of your breast cancer was the same. So yes, some breast cancers come back, but some breast cancers are also just easier to treat than others. And what that tells me is whether or not you're going to have a good outcome from your breast cancer has much more to do with this information up here, the biology of your tumor, than it does the information down here, what you choose to do to your breast. Now, that being said, if the outcomes are the same, then how do we choose? Why are some people getting mastectomies then and some are getting breast conservation? For me, it has to do with the breast to tumor size ratio. If you have a small breast and a large tumor, there's not as much breast to conserve. There's also the possibility of multifocal breast cancer, meaning it's present in multiple parts of the breast. Sometimes the type of breast cancer, lobular breast cancers, are more likely to be harder to detect and more likely to be multifocal. Of course, there's the family history and genetic workup that Dr. Smith talked about. If you have a high risk gene that shows that you are very highly likely going to have a recurrence of your breast cancer, we'll talk more about aggressive treatment. Whether or not you've had prior breast cancer in that breast, including radiation to that breast, and that may make it so that you can't do radiation again, and we recommend mastectomy in those cases. And of course, there's patient preference, and I listen to every patient's story as they come in and listen to it change over time, and sometimes we have to talk on the phone or meet up again before we really know what we want to do. So let's talk about mastectomy. There's simple mastectomy, is that drawing I showed you before was, and there's also skin or nipple sparing. We don't do a lot of nipple sparing mastectomy around here, and it really isn't for every patient. Your cancer has to be well away from the nipple and is usually done in concert with reconstruction, which we'll discuss in a bit. Skin sparing I usually only do if I know somebody's going to get reconstruction. I'm trying to preserve as much of the skin as possible for the reconstructive surgeon. So how do we manage excess skin? Well, thin women with smaller breasts can have an outcome like this that looks very flat and neat. But more overweight women tend to have a harder time getting that same flat outcome. And I think that we need to set realistic expectations based off their body size, what their mastectomy incision might look like. You can expect an overnight stay, and you can expect a drain to be in place for about a week to kind of pull out excess fluid and allow the skin to adhere to the chest wall. And then we give you exercises at your post-operative appointment to help loosen the chest wall, and consider occupational therapy for any scarring. This is a chest compression device. For lumpectomy, the biggest thing is, how do we find the mass? Occasionally I can feel the mass, and that's quite easy, but most of the time, thankfully, because mammograms are doing a great job, we're finding these masses much smaller. And at the time of your surgery, of your procedure, when they do the biopsy, they place a very tiny inert titanium clip in the mass. Now, this marks it on mammograms and is placed for any biopsy, whether or not it's cancerous or non-cancerous. And on the day of surgery, I need something a little more concrete to tell me that it's there. So we actually use something called the mag seed here. So it'd be an additional procedure to have this slightly larger, less inert metal clip placed right next to the titanium one. And then I have, again, something like a metal detector that beeps very loudly when I get close to it. So you can see that now there's a mag seed clip in there sitting next to the other clip, and I can use my other detector to get close to it. And then once I remove the mass, I send it to radiology and they take an x-ray for me. And that will tell me that not only do I have the clip and it's centrally located, but I have lots of normal breast tissue around it. So that increases our chances of having gotten it all at the time of surgery. Let me see if there was anything else there. This tends to be an ambulatory surgery. There's no drains placed. There's minimal activity restrictions, and people tend to return to their regular activities much faster. So as far as breast reconstruction goes, we don't do breast reconstruction here. Maybe someday, but not now. So you would get a referral to a reconstructive surgeon and hopefully meet with them even before you undergo your surgery or as you're trying to decide about mastectomy versus lumpectomy. There's immediate reconstruction, meaning done at the same time as the mastectomy, which is much rarer, especially in active cancer, more often done for people having their breasts removed for genetic issues like BRCA, or more commonly delayed reconstruction. So I or one of my partners does your mastectomy, and sometime in the next few months, maybe after you're done with your treatments with Dr. Smith, you go on to reconstruction. So further dividing up, there's implant-based reconstruction, where a tissue expander is placed underneath the skin or muscles, slowly expanded to stretch out the skin to the desired size. And then you can see here what a typical implant-based reconstruction looks like. So it doesn't look like getting breast implants if you have native breasts there. It will never quite look that good, but it can certainly make you feel a little more comfortable in a shirt and bra. And then there's, so this is multiple surgeries, but each one of them is fairly simple. And then there is tissue-based reconstruction. This is most commonly what we call a DIEP flap, or deep inferior epigastric perforator flap, where we remove skin and fat from your abdominal wall and reconstruct the breast using that. And it actually gives you a bit of a tummy tuck at the same time. And this is a outcome you could expect from that surgery. And you can see that the breast itself just looks a little more natural, and you don't have to worry about an implant and complications related to that down the line. Now, this is a much bigger surgery, typically a single surgery, but it is many, many hours long and requires multiple days in the hospital, including an ICU stay, and not everybody's a candidate for it. Additional procedures can include nipple formation and tattooing, as well as fat grafting. Again, all of this is done by the breast reconstructive surgeons. So just quickly about recovering from your surgery. These surgeries are not usually as painful as you might expect. In fact, most patients don't use narcotics for more than 1 day after surgery. I recommend you find a comfortable front closure bra. And then you can expect, if you have mastectomy, that you're going to have drains, and we provide a camisole with drain pockets, not quite like this drain belt, so that you don't have to juggle those drains, and a drain log, as well as and so that you can keep track of how much is coming out of your drains. And then at your follow-up, I give you a prescription for a post-mastectomy bra that can be filled multiple places around town. And then what you can get for yourself, there's these wonderful post-mastectomy pillows that provide a little pressure and support as you're resting. And that's all I was going to talk about today. Sorry, we went a little bit over there. So I know I said I was going to talk about saving your rack, but sometimes the right thing to do is lose your rack. And we just try to guide patients through the process, making sure that we individualize our treatment and get you what works best for you, your family, and your cancer. Thank you very much.
And thank you all for hanging on a few minutes. We did have a few questions roll in. So the first question came in before we got started, and it was talking about the recommendations for screening, changing. What's your view on this? But I feel like Dr. Smith, you gave a really fantastic overview that really expanded screenings. From my knowledge, it was kind of like cut and dry. And then I'm like, wow, there's so much more to consider in Vantage Point. So if anybody wanted anything clarified with that, maybe do a follow-up question, but I feel like we answered that one. And then the second question is there a breast density number to track if it increases?
Yeah, I saw that one on there. And as Dr. Smith showed, there is a gradation of density that the breast radiologists do use to describe each mammogram. And breast density does change over time, particularly as you go through menopause and your breasts go from being more glandular to a little more fat-based. So yes, that number is recorded in each mammogram. and may change over time. I hope that answers that person's question.
Okay, that's helpful to know that the density normally changes. And just to have that awareness. I don't know if other people, that's on other people's radars, as it's a newer thing to be monitored. And then another question was kind of asking for clarification between diagnostic and screening mammographies. This person had some samples, some small lumps removed years ago, and now their mammograms are considered diagnostic and screening. So any clarification on that would be helpful.
Dr. Smith may know a little bit more than me about this, because obviously people have, by the time I'm meeting people in clinic, they've gone through the whole diagnostic procedure. So I don't do a lot of screening work. However, I know that in general, diagnostics are used when we are looking for something specific, and screening is just more of a generalized overview. Now, if somebody had masses removed, benign masses removed years ago, unless there is something specific that we're continuing to follow that wasn't removed, I wouldn't imagine those would be diagnostic. I would think they'd be screening. But if there are still masses, cysts, or other benign things that they're following closely, those would be still considered diagnostic mammograms. And I probably shouldn't say this, but it's truly a bummer that insurance doesn't still requires copays for those diagnostic mammograms. I definitely am on board with the person who wrote that question, that's probably not fair.
Yes, totally hear that. And thanks. That was really helpful. And, the hope is with conversations like this, that our attendees just have so much more knowledge to know what's actually going on, and able to ask really, intelligent questions at their next doctor's appointment. So, and they have some familiar faces to go to as well. So
yeah, they know exactly what I'm going to draw on my notepad. So
that was cool. I liked that.
I did see that Teresa put something in the chat that says the second picture, Dr. Smith said, when to get a first baseline, and what is that? I don't know if Julie wants to answer that, because it was directed more towards her.
So a baseline mammogram, the very first mammogram is the baseline mammogram that serves for all future mammograms. So the very first mammogram a woman has is considered the baseline. After specific things occur to a breast, for example, after a biopsy, after lumpectomy, after breast cancer treatment, that breast is going to change, right? There's going to be a scar. It's going to look different on all future mammograms. So the next mammogram that happens after breast cancer treatment is a new baseline that serves moving forward. I will also add, though this gets back to the diagnostic versus screening, the first, if not the second mammogram that occurs after breast cancer diagnosis is recommended to be a diagnostic, because that baseline has changed, because we expect to see new retraction or scarring or a different tissue. So after that first and second new baseline mammogram and has occurred during that first and second year after breast cancer treatment, the majority of women then go on to yearly screening bilateral mammography.
Right, I think that's all the questions. I'll put in the chat, you can follow and see what's coming up next at ncwlibraries.org, or follow us on Facebook at NCW Libraries. But that's everything. So thank you so much, and I hope everybody has a wonderful evening.